Imagine a patient walks up to your pharmacy counter or, maybe your clinic desk, and they're just complaining of this stubborn, completely blocked runny nose.
Right, and they're tired, they're frustrated.
Exactly. They just want relief. So
Yeah.
you hand them a standard over-the-counter decongestant spray, right? You think, okay, I've solved the problem.
But what you might have actually just done is missed the early warning signs of a destructive cranial tumor.
Yeah.
Or, I mean, perhaps slightly less dramatic, but way more common, you just handed them the exact pharmacological tool that's going to trap them in a miserable cycle of permanent chemically induced congestion.
It's terrifying when you frame it like that. But today's deep dive is a comprehensive, textbook-accurate clinical masterclass on rhinitis. And our mission is to transform these dense clinical texts into a truly practical, counter-ready diagnostic tool for you.
It's an incredibly tempting trap for clinicians to fall into, honestly. The presentation just feels so entirely routine.
We see it constantly.
Right, so our brains tried to take a shortcut. We use fast, intuitive type 1 thinking. We hear the words runny nose and sneezing, and we immediately jump to the most common conclusion.
Right, which leads to this massive cognitive bias known as search satisficing.
Exactly.
Okay, let's unpack this. Search satisficing is essentially when you start looking for clues the exact second you find an answer that sort of fits the picture, right?
And that's it perfectly. You are satisfied with the search, so you just terminate it prematurely.
The patient says, I'm sneezing. You think, allergies, and you completely stop asking questions.
And it's a huge source of diagnostic error. It happens in roughly 10 to 15% of all primary care consultations.
Wow, 10 to 15%.
Yeah. To avoid this, we have to deliberately force our brains into slow, analytical type 2 thinking. We must gather specific clinical cues and construct a very precise problem representation before we even think about reaching for a product on the shelf.
So let's zoom out for a second and apply that type 2 thinking to the very foundation of the disease. Because to properly treat the patient standing in front of you, we first have to understand exactly what is happening inside their nasal cavity at a cellular level.
Right, the moment they encounter a trigger.
Right.
Because it's not just, dust going in and mucus coming out.
It's a highly orchestrated inflammatory cascade. So let's break down the timeline of classic allergic rhinitis. First, the patient comes into contact with an allergen.
Say heavy load spring pollen or microscopic fungal spores.
Right. And this allergen gets inhaled and physically lodges itself within the protective mucus blanket that lines the nasal membrane.
Exactly. Now, if this patient is already sensitized, they have specific immunoglobulin E, or IgE,
Yeah.
antibodies. And these are just resting on the surfaces of their mast cells within the nasal tissue.
And these mast cells, they're basically just packed full of inflammatory chemicals, right? Just waiting for a signal.
Precisely. The allergen binds to those resting IgE antibodies, and it cross-links them.
Which is like a physical bridging.
Yeah, that physical bridging sends a signal straight into the mast cell, triggering immediate degranulation. The cell essentially bursts open, releasing just a flood of potent preformed chemical mediators.
Like histamine.
Primarily histamine, yes. But the cascade quickly synthesizes leukotrienes, kinins, and prostaglandins as well.
And this rapid release creates what we clinically call the early phase allergic reaction.
Right.
So explain how those specific chemicals translate into the symptoms the patient actually feels, like within minutes at the counter.
Well, the histamine binds to H1 receptors on the sensory nerve endings in the nasal mucosa. This sends a really rapid signal to the brain that the patient interprets as an intense, maddening nasal itch.
Oh, that deep itch you can't scratch.
Exactly.
Yeah.
Simultaneously, those stimulated nerves trigger a reflex arc that causes paroxysmal sneezing.
Those sudden, violent bouts of multiple sneezes in a row.
Yeah. Meanwhile, kinins and histamine are acting on the local blood vessels, causing massive vasodilation and plasma leakage. So fluid just rushes out of the capillaries and into the nasal cavity.
Giving you that classic, profuse, watery rhinorrhea.
Exactly.
But, I see patients who take an antihistamine, their sneezing stops, their nose stops running, but they come back the next day complaining that they still cannot breathe. Why does the presentation shift like that?
Because 4 to 12 hours after that initial allergen exposure, the patient enters the late phase reaction.
Okay.
And this phase isn't driven by the quick hit of histamine. It's driven by the influx of other immune cells, like eosinophils, and the prolonged action of leukotrienes.
So the antihistamine doesn't even touch it.
Right. During this late phase, the vascular permeability is so profound that the nasal tissue itself physically swells. The turbinates just engorge with blood and fluid. At this point, nasal congestion becomes the dominant, overwhelming symptom.
Completely blocking the airway. So if we are building our clinical picture, the classic counterpresentation of intermittent allergic rhinitis, what we call the golden symptoms, are basically bilateral symptoms developing within minutes of exposure.
Yes. Specifically, watery rhinorrhea, intense itching of the nose or conjunctiva, paroxysmal sneezing, followed by that heavy nasal congestion.
But what about the severity over time? A lot of patients swear their allergies get way worse at the end of the season, even when the pollen counts are officially dropping.
What's fascinating here is the cellular mechanism of nasal priming. The nasal mucosa actually changes its physical threshold for reactivity over time.
I've heard this explained like a bucket filling up with water, where eventually even a single drop of an allergen makes it overflow. But does that really explain the cellular mechanism to a clinician? Like, what is actually changing in the tissue?
A better way to think of it is to imagine those mast cells like a neighborhood watch program. Normally, they just lightly patrol the tissue, but continuous pollen exposure over weeks is like a barrage of constant break-ins.
Oh, I see.
When mast cells get primed, they literally recruit and call in backup, drastically increasing the sheer number of inflammatory cells, like eosinophils, resting in the nasal epithelium.
So the neighborhood is now heavily guarded.
Heavily guarded and so on edge that even a tiny, previously harmless amount of allergen triggers a massive disproportionate inflammatory alarm.
Because of this cellular hyperreactivity, patients suffer severe symptoms even when pollen levels are objectively low. That makes total sense. Okay, so we know what classic allergic rhinitis looks like at the cellular level, but how do we definitively separate it from its primary mimics?
Right, using the Murtaugh process.
Yeah, in a busy clinic, how do we tell the difference between a virus, an allergy, and something else entirely without, running a lab test?
The first step in establishing a differential diagnosis is using the ARIA guidelines. That's the allergic rhinitis and its impact on asthma guidelines.
We categorize the rhinitis based on its temporal pattern, right?
Exactly. Is it intermittent, meaning it occurs less than 4 days a week and for less than 4 weeks? Or is it persistent, occurring more than 4 days a week and for more than 4 weeks straight?
And persistent allergic rhinitis presents a bit differently than the classic intermittent seasonal hay fever.
It does, largely because persistent allergic rhinitis is usually triggered by indoor year-round allergens, things like house dust mites or animal dander.
Because the exposure is constant, day and night.
Right. These patients present with chronic heavy nasal congestion. That swelling physically blocks the olfactory cleft, leading to hyposmia, which is a reduced sense of smell.
Oh, wow.
And interestingly, because they are constantly exposed, they often experience less frequent sneezing and fewer watery eye symptoms compared to the acute seasonal sufferers.
But let's say a patient comes in, they have clear discharge, they have no fever, so it's not a cold, but they swear they do not have allergies. Their eyes aren't red, they aren't itchy. They tell you they just walked into a cold, heavily air-conditioned supermarket and their nose instantly turned on like a faucet.
That is a classic case of non-allergic or vasomotor rhinitis.
What is happening there?
This isn't an immune system reaction at all. It is essentially an autonomic nervous system glitch. The blood vessels in the nose are controlled by a balance of sympathetic and parasympathetic nerves.
Yeah.
In vasomotor rhinitis, there is either an overactive parasympathetic response or a hypoactive sympathetic response to environmental changes.
So the triggers aren't proteins like pollen or dander. The triggers are physical or chemical irritants.
Exactly. Dry air, pollution, strong perfumes, spicy foods, or sudden temperature changes. The nerves overreact to the physical stimulus and dilate the blood vessels.
Clinically, it looks very similar to allergic rhinitis, but if you ran an IgE allergy test, it would be completely negative.
Spot on. There are two key differentiators here: age of onset and sensory symptoms. Vasomotor rhinitis typically starts later in life, usually after the age of 20, whereas allergic rhinitis often starts in childhood.
And critically, that hallmark symptom of intense nasal itching is almost entirely absent.
Yeah.
Here's where it gets really interesting, though. If a patient just says, my nose is blocked, how do we instantly rule out a cold? We know there are over 200 viral subtypes that cause infective rhinitis.
It all comes down to specific visual cues and the clustering of symptoms. First, look at the discharge.
Okay, what are we looking for?
In an allergic or vasomotor reaction, the rhinorrhea is clear, thin, and watery. In insective rhinitis, a viral cold, that discharge typically evolves over a few days to become mucopurulent.
Ah, so it becomes thick, opaque, and often discolored.
Exactly, as white blood cells rush to fight the virus.
So watery versus mucopurulent, what is the next clinical divider?
The nature of the sneeze and the itch. Allergic rhinitis features those rapid-fire bouts of multiple sneezes. That's quite rare in a common cold.
Right. You might sneeze once or twice with a cold, but not 5 times in a row.
Yeah. But the ultimate dividing line, the symptom that really points you away from a virus and squarely toward an allergy, is the presence of an intense nasal or ocular itch.
Because viruses destroy epithelial tissue, they don't typically trigger a massive histamine release.
Exactly. So you rarely see severe itching with a viral infection. Furthermore, a cold will almost always bring along other systemic or localized symptoms.
Like a harsh cough, a sore throat, or general malaise.
Right, which are much more prominent than in simple allergic rhinitis.
That creates a very clear diagnostic pathway. But we have to address one more major mimic, and it's one entirely caused by the patient's own actions. Rhinitis medicamentosa.
Yes, medicine-induced rhinitis.
This is caused by the prolonged, unguided use of topical sympathomimetic decongestants, right? The over-the-counter nasal sprays.
Specifically when used for more than 5 to 7 days.
Explain the exact mechanism here, because patients don't understand how a drug designed to open their nose ends up closing it permanently.
Well, these topical decongestants work by stimulating alpha-adrenoceptors on the blood vessels in the nasal mucosa. This causes them to constrict tightly, which rapidly opens the airway.
But if a patient uses that spray continuously,
The constant artificial stimulation forces the body to adapt.
Yeah.
The alpha-adrenoceptors actually downregulate. They become desensitized and fewer in number.
so the body builds an aggressive tolerance.
Exactly. When the drug wears off, the vessels dilate far beyond their original state, creating a massive rebound vasodilation.
The patient feels incredibly congested, so they use more spray.
But now they have fewer receptors, so they need more drug just to get a baseline effect. The receptors downregulate further, and they get trapped in a vicious cycle of permanent, chemically induced congestion.
That no longer responds to normal environmental cues. We'll talk about how we medically bridge them out of that trap in a moment, but right now we need to address the absolute most critical part of the consultation, the universal red flags.
Yes, the strict referral criteria.
If you're at the counter right now listening to this and a patient asks for allergy medicine, what are the specific diagnostic pause moments where you have to abandon self-care and initiate an emergency referral?
The absolute strictest rule in any rhinitis assessment is evaluating whether the symptoms are unilateral or bilateral.
Okay, unilateral versus bilateral.
Allergic rhinitis, vasomotor rhinitis, and viral colds are characteristically systemic or environmental, meaning they affect both sides of the nose. They are bilateral.
So if a patient has bilateral blockage, but it absolutely fails to clear despite antihistamines and steroids, what are we thinking?
We suspect nasal polyps. Polyps are benign growths of inflamed tissue. They're usually bilateral, and as they grow, they cause a physical obstruction, loss of smell, and sometimes a dull sinus pressure.
They require medical management, but they aren't immediate emergencies.
Right. However, if a patient presents with any one-sided unilateral discharge or obstruction, you must view that with intense suspicion. The consultation changes immediately.
And the specific red flags depend heavily on the patient's age, right? Like, if a parent brings in a 4-year-old child with a runny nose, your first instinct might be to check for a fever. But you're saying your actual first look should be to see if that discharge is coming from one nostril or both.
Absolutely. If a young child presents with unilateral nasal discharge that is mucopurulent, foul-smelling, or blood-stained, this requires a same-day general practitioner referral.
Because it strongly indicates a trapped foreign body in the nasal cavity.
A bead, a piece of food, a small toy. The tissue reacts violently to the foreign object, creating localized purulence, and the necrotic tissue buildup creates a classic, undeniable foul smell on just one side.
Wow. And what if the patient is an older adult, say over the age of 50, presenting with unilateral symptoms?
In that demographic, a unilateral nasal obstruction or bloody rhinorrhea is highly concerning for malignancy.
Like a tumor.
Right. If that single-sided symptom is accompanied by severe facial pain, hearing loss in one ear, persistent swollen lymph nodes, or signs of cranial neuropathy like facial numbness or double vision, this mandates an urgent referral.
To rule out things like a squamous cell carcinoma or a benign but highly destructive angiofibroma. But let me push back on this, though.
Okay.
A simple deviated septum can also cause unilateral blockage, and it's incredibly common. How do we differentiate a structural fault at the counter so we don't accidentally terrify a patient by implying they might have a tumor?
If we connect this to the bigger picture, it always comes down to the clustering of symptoms. A deviated septum is a static structural fault.
Static, right.
It reduces airflow on one side, and the drying effect of that altered airflow might cause some mild crusting or occasional minor bleeding. The patient will often report a lifelong history of noisy breathing during sleep.
But it completely lacks the aggressive, progressive warning signs of a tumor.
Exactly. A deviated septum doesn't cause sudden facial numbness or double vision. It doesn't cause a foul, necrotic smell. It's the presence of those progressive, destructive symptoms alongside the unilateral blockage that dictates the urgency of the referral.
All right, so we've successfully navigated the differential diagnosis. We've ruled out the viral infections, the vasomotor mimics, and the critical unilateral red flags. We have a confirmed diagnosis of allergic rhinitis.
Now we shift into type 2 analytical thinking for our management plan.
What is the exact evidence-based pharmacological protocol we deploy?
Management always begins with identifying the trigger and applying non-pharmacological interventions. This is especially true for persistent allergic rhinitis, which is predominantly driven by house dust mites.
I want to focus on this because just telling a patient to clean more is totally useless advice. The clinical pro tips here require understanding the mite's life cycle.
Yes.
We need to advise washing bedding and mattress covers wintly at temperatures above 60 degrees Celsius, because anything lower won't actually kill the mites, it just gives them a warm bath. And a huge one, strictly avoiding drying wet clothes on indoor radiators.
That is a critical piece of advice.
Yeah.
Dust mites thrive in high humidity. Drying clothes on a radiator drastically raises the ambient indoor humidity, creating a perfect warm microclimate for mites to rapidly reproduce. You have to control the environment first.
Once we do that, we look at pharmacology. For mild intermittent symptoms, we generally start with systemic therapy, specifically oral antihistamines.
Right.
I see a lot of clinicians still recommending older first-generation antihistamines like chlorphenamine because patients sometimes think a drug that makes them drowsy is somehow stronger. But we should be aggressively pushing back on that, right? Why are we prioritizing second-generation drugs like loratadine or fexofenadine?
It comes down to their pharmacokinetics and how they interact with the blood-brain barrier.
Okay, break that down.
First-generation antihistamines are highly lipophilic, meaning they dissolve easily in fats and rapidly clog the blood-brain barrier. Once in the central nervous system, they block the histamine pathways that keep us awake and alert.
Causing profound sedation and cognitive impairment.
Exactly. Second-generation drugs, however, are engineered to be bulky and highly water-soluble. They physically struggle to cross the blood-brain barrier. They selectively inhibit peripheral histamine H1 receptors, stopping the allergic cascade in the nasal tissue without shutting down the patient's brain.
And there are important nuances between the second-generation options regarding half-lives.
Correct. If a patient needs consistent 24-hour coverage, cetirizine dosed at 10 milligrams once daily is excellent.
But what if their symptoms are highly variable? Maybe they only get flare-ups when they visit a friend with a dog.
Then the shorter half-life of acrovastine is ideal. Dosed at 8 milligrams up to 3 times a day, it gives the patient flexible, dial-it up or down control without locking them into a full 24 hours of systemic drug exposure.
But there is a major clinical caveat with all oral antihistamines. We established earlier that histamine drives the early phase reaction, the itch, the sneeze, the watery discharge.
Yeah.
But histamine does not drive the late phase reaction. So if a patient takes loratadine, it won't do much for their heavy nasal congestion.
Exactly. And that brings us to the gold standard of topical therapy, intranasal corticosteroids. Medications like beclomethasone, fluticasone, budesonide, and mometasone.
Clinical trials consistently demonstrate that these are the most effective overall treatment for moderate to severe allergic rhinitis.
By binding to glucocorticoid receptors inside the cells, they actually downregulate the transcription of pro-inflammatory genes. They shut down the entire cascade, making them superior to antihistamines for all nasal symptoms, including that stubborn late-phase congestion.
The standard dosing protocol is usually 2 sprays into each nostril once daily. But the counseling here is make or break.
Absolutely.
If you just hand a patient a steroid spray and ring them up, they will almost certainly fail therapy. You have to explicitly explain 2 mechanical aspects. First, these medications are suspensions. The active drug particles settle at the bottom of the liquid.
Right, so the bottle must be vigorously shaken before every single use, or they are just spraying inactive solvent into their nose.
And second, you must manage their expectations regarding the onset of action. Because steroids work by altering gene transcription inside the nucleus, the process is inherently slow.
It takes roughly 12 hours just to begin working, and it can take up to 2 full weeks of regular daily use to reach maximum clinical efficacy and fully reduce the tissue swelling.
Which creates a massive clinical dilemma. What does this all mean for the patient standing at the counter who hasn't slept in 3 days because their nose is completely blocked?
They do not care about gene transcription. They want to breathe right now.
Exactly. We know that topical decongestants, the sympathomimetics like xylometazoline spray or ephedrine drops, they provide that instant relief. But we just established that using them downregulates alpha receptors and causes rhinitis medicamentosa.
This raises an important question. How do we ethically treat their immediate suffering without trapping them?
Right.
This is where clinical strategy bridges the gap between acute symptoms and long-term control. The evidence-based compromise is this. We can utilize topical decongestants, but we must strictly time-box them to a maximum of 5 to 7 days.
Just long enough to open the airway while the primary treatment boots up.
Precisely.
Right.
We use the sympathomimetic spray purely for instant, acute relief, while simultaneously starting the intranasal corticosteroid spray on day 1.
Oh, because the decongestant shrinks the swollen tissue immediately, it actually allows the steroid spray to penetrate deeper into the nasal cavity, improving its distribution.
That's the beauty of it. By the time we aggressively withdraw the decongestant at day 5, right before receptor desensitization occurs, the corticosteroid has had enough time to build up in the tissue.
It has altered the gene transcription, reduced the underlying inflammation, and can now take over the heavy lifting of keeping the nasal passages clear.
It requires highly precise patient education, but when executed correctly, it is the most effective management strategy we have.
For everyone listening, you have just successfully navigated the true clinical pathways of rhinitis. We've established that clinical reasoning isn't just passively listening to a complaint.
It is actively hunting for specific data to avoid search satisficing.
It's looking for the bilateral golden symptoms and the precise visual cues of clear versus purulent discharge. It's aggressively screening for the unilateral red flags that point to foreign bodies or malignancies, and it's expertly managing patient expectations by bridging the gap between the delayed onset of topical steroids and the immediate relief of decongestants.
It's comprehensive care.
Before we go, consider this. We've spent this entire deep dive talking about managing the physical mechanics of rhinitis, the swelling, the discharge, the structural airways. But think about the cognitive load on the patient.
It's immense.
Studies suggest that the chronic sleep disruption, the constant microarousals, and the mild hypoxia stemming from persistent severe rhinitis can impair a student's exam performance or a driver's reaction time almost as much as being at the legal alcohol limit.
Wow.
And consider the paradox of the stuffy nose. The very over-the-counter nasal sprays a desperate patient reaches for to breathe freely, those topical decongestants, are the exact mechanism that ultimately downregulates their alpha adrenoreceptors, literally reprogramming their nasal arterioles to trap them in a permanent state of rebound congestion.
Sometimes in pharmacology, the cure becomes the disease.
So the next time you are at the counter treating a simple runny nose, remember, you might not just be clearing an airway. By applying this level of rigorous type 2 clinical reasoning, you might be saving their livelihood or even their life. Thanks for joining us on this deep dive.